A young patient presented with deep caries involving the pulp of an immature permanent tooth. A devitalizing agent had been applied at another clinic for 2 hours, after which it was replaced with calcium hydroxide. The patient then sought further treatment at our clinic. Electric pulp testing EPT and cold testing show responses comparable to those of the control tooth. Radiographic examination reveals incomplete root development. A distinct perforation is visible at the distal pulp horn, with radiopaque material visible in the adjacent area. Periodontal ligament anesthesia using a painless anesthesia device. Carious tissue and temporary filling material are removed using an electric motor in high-speed mode. The surgical site is disinfected after approaching the pulp exposure area. Instruments and gloves are replaced. Using an electric motor with sterile ice-cold saline 3000 revolutions per minute. A round burr is advanced toward the pulp chamber roof to remove the devitalized and contaminated coronal pulp. After secondary disinfection of the surgical site, sodium hypochlorite and ice-cold saline are used for irrigation. Hemostasis is achieved at the pulp exposure site, and pulp status is assessed. Place calcium silicate-based bioactive material. Tightly cover and seal the pulp exposure site. Radiographic evaluation confirms a dense and complete seal of the pulp capping material. At the 3-day follow-up, cold testing and EPT responses remain comparable to the control tooth. Traditional endodontic theory holds that the application of a devitalizing agent marks the transition of pulp tissue into an irreversible state. However, current evidence suggests that the duration of exposure and the inherent regenerative capacity of young pulp tissue are key factors determining reversibility and long-term success rates. In a case report published by Hristov in 2021, regenerative pulp therapy was ultimately performed on an immature permanent tooth that had previously undergone pulpal devitalization. A 24-month follow-up revealed that the affected tooth remained asymptomatic, with continued root wall formation and apical closure. This suggests that pulp and dentin tissues exposed to devitalizing agents do not necessarily lose all potential for vitality preservation. The rich vascular distribution of the pulp in young permanent teeth acts as a biological buffer. In the presence of toxins or inflammatory mediators, blood flow facilitates the rapid clearance of metabolic byproducts and the delivery of defense cells. When chemical devitalizing agents are applied, the outward pressure of the pulp fluid and high microcirculation rate initially resist the apical diffusion of the chemicals. In young permanent teeth, the pulp chamber is relatively large, and the tissue contains a large amount of growth factors encapsulated within the dentin matrix, such as bone morphogenetic proteins BMPs and transforming growth factor beta TGF-beta. When biocompatible materials are applied, these factors are released, triggering a reparative response even following minor chemical damage. Studies have shown that formaldehyde gradually diffuses into the pulp tissue. Within the pulp chamber, polymerized formaldehyde and its depolymerized form moves slowly through dense connective tissue. As early as 30 minutes after application, its presence can be detected in the dental structure, but during the first few hours, the local concentration remains relatively low. Formaldehyde concentration increases logarithmically within the first 24 hours after application. At the 2-hour mark, the fixation front likely affects only the most superficial layer of the coronal pulp. 4 first molars with large crown volume, a 2-hour period, is insufficient for the irreversible protein denaturation caused by formaldehyde to reach the radicular pulp. Current molecular biological evidence suggests that formaldehyde-induced DNA protein crosslinks do not necessarily persist beyond 10 hours. They may undergo spontaneous hydrolysis or be actively repaired through cellular proteolytic pathways. If the source of formaldehyde is removed within 2 hours, cells located deep within the dental pulp receive only sublethal doses, enabling activation of repair mechanisms. This biological recovery explains why the pulp in this case retains sensation, responds to EPT and cold testing, and does not progress to complete necrosis. Total pulpotomy involves complete removal of the coronal pulp to the level of the pulp chamber floor or slightly into the canal orifice. This procedure is indicated when the pulp is irreversibly inflamed, or when chemical changes have occurred, as in this case. Unlike partial pulpotomy, which removes only 1 to 3 millimeters of tissue, total pulpotomy provides a greater safety margin. When chemical toxins are introduced into the pulp chamber, for permanent teeth with irreversible pulpitis, clinical trials and retrospective studies show success rates ranging from 85% to 100% over a 1 to 2 year period when bioceramic materials are used. A study using bioceramic materials to treat 28 permanent teeth shows, during a 12-month follow-up, 100% remain asymptomatic. 92.8% form a visible calcified bridge. This indicates that the material is highly reliable. Postoperative follow-ups must be conducted at 3, 6, 12, and 24 months. This is to verify long-term pulp health and root integrity. In such cases, factors contributing to a higher success rate include the patient's age. The high metabolic activity and strong healing potential of adolescent pulp are critical. The short exposure duration falls entirely within the reversible window of formaldehyde-induced cellular cross-linking. Strict aseptic techniques and temperature control throughout the procedure minimize the risk of iatrogenic trauma. The use of non-resorbable, high-pH bioactive sealants provides the optimal environment for the formation of a permanent dentin bridge.